And this is an important group because if we could stop a problem here, person will not go here. We can still work here and prevent it from here or here, but ideally we should stop it here somewhere so that a normal person either doesn't get it, or if a person gets it, it's stopped right there and then. So even some people would say even this is too late, and it is. Because it is already, the disease has already set in. If we had the ideal way, which I don't know how long it's going to take, but the ideal thing would be that we find people who are at risk at going in this direction, and we can stop it here, so that normal people would not get it. For example, for people who are 55, 50 years of age, know that they undergo colon screening for colon cancer. The purpose is that if the colon cancer could be diagnosed early or symptoms can be checked, it could be prevented. Breast cancer, something like that. If we could have ways like those, yes, we could. But right now, we are not there. Our goal should be that we could prevent Alzheimer's disease by finding the people who are at risk and doing something about them and have treatments or something that we could prevent it. But short of that, we are working on this area. And the concept of this early stage and mild cognitive impairment is shifting backwards, because we are realizing that, we need to do it even before that we are doing right now.
Do you have ways to diagnose that very early stage?
Yes, we will. There are ways that are still in the process, but we do have better and better ways than we used to have. So I'll quickly go over a few things. We spend more time on some of these things than I anticipated, but so there are differences. Your question would be, let's see here. Your question could be that, so how do you differentiate? And I earlier pointed out some of the differences between normal aging and MCI. So, and your question about how you diagnose. One way to diagnose is that by clinical assessment. There are differences in the quality of memory impairment that happen in normal aging and people who are on their path to Alzheimer's disease. Their memory impairment is beyond what is expected for people of their age over a period of time. So like I suggested, if it's progressive, that kind of hints towards a more dangerous pathway than if it's not progressive. We also look at beyond memory. Is memory the only thing affected, or is there a language or their ability to problem solve or reasoning also affected? Are they having problems in their ability to do things? So they may be playing golf, but their game is not as good as it used to be. Not because they have physical limitations, but they have other problems. Or they may say, I have stopped going with my friends because, I don't feel comfortable. Or they won't take the challenge as they used to take about a year or 2 years ago. That shows a difference. So some of these assessments and evaluations help us. So we ask certain questions in certain ways. There are tests developed too that can help us differentiate. Because those changes that happen between, differences between normal memory and mild cognitive impairment are also shown on some of the brain exams. There are sophisticated imaging studies. There are MRIs which are still research quality, and you are not able to get them just by having a prescription from your doctor, which can look at certain deep parts of the brain and say, yes, the changes are in line with Alzheimer's type of changes. These are things called, hippocampus I showed. There's a term called entorhinal cortex. And these changes could happen, some may say, 10 to 20 years before a person starts noticing it. Now, more recently, the term prodromal Alzheimer's disease has been introduced.
Would you repeat that?
Prodromal Alzheimer's disease. So it's sort of a, it's there where memory changes with better confidence we can say that a person's memory changes are the result of Alzheimer's disease. And the way we do it, that the clinical assessment, where we do assessment of how their memory is, where they stand compared to their age and education. Is it getting worse or is it staying the same? What other areas of cognitive functions, the language and executive functions are affected? We also look at their MRIs. MRI can look at the volume of total brain. It can look at how the brain cells are concentrated, what's the density there, and also look at a spinal fluid. Spinal fluid is a fluid that goes around the brain and goes back to your spine. The body produces it and it's in circulation. And it's the closest you could get to the brain in living person. I mean, you can see the MRI, but the closest fluid we can get from around the brain is spinal fluid. So you will see that all the research that is going in Alzheimer's disease, majority of them are asking that either you participate in spinal fluid analyses, and they offer it because it is an important way. It's the only way that we can find out what chemicals are coming in and out of the brain and in what concentration. You have heard names like amyloid plaques and tangles. They release and they kind of give some of the proteins that go into the spinal fluid. And the way we could look at the amount of those proteins is by getting the spinal fluid. The spinal fluid, it sounds kind of little, it gives you a shiver, but it becomes so simple compared to what it was 10, 20 years ago. One of the things I explain to my patients is that, don't be scared. This is something that women get at childbirth. Epidural anesthesia, that's a spinal tap. That's where the needle goes in, and it is not, when it's done in labor room, it's not done as sophisticated as it's done in research. Well, somebody commented that, you're already in so much pain, so who cares about that pain? So I could not relate to that. But that's, so yes, the spinal fluid is an important part of all investigation. Now you may say that, why can't we have just one test? But in medicine, no matter where you look, there is never ever a one test for anything. I wish there was a test of I can have somebody sit with me for 5 minutes, do a quick test or a blood draw and say you have this disease or you don't. But that doesn't happen. All diseases, I think that's what they call it, they are a puzzle. And you have to fit those pieces before you can say this is it. Sometimes it's a complete puzzle, sometimes it's 80%, 90%, sometimes 50%. But that's how life comes to us. It's never going to be simple, and I don't want to make it simple. So prodromal Alzheimer's is our best way to move backwards in our diagnosis. And what we do is we put these pieces of puzzles together. So we say, okay, I checked your memory is this. I sent you to a neuropsychologist and he or she told me that these are the areas of the brain that are affected. This is also going in line with your Alzheimer's type change. Then I sent you to get an MRI or a CAT scan, and the brain is not showing any stroke, doesn't have any kind of tumors. The changes in the brain, the shrinkage of the brain is going along my impression that this is Alzheimer's type. Then I may send you to a spinal fluid analysis and say, the protein ratio that you have is also going in that direction. I would never be able, at this point, I'm not able to tell you that, okay, I have 100% confidence that this is it, there's nothing else. But I can say with good assurance that in my opinion and my experience, this is very likely close to 90%, this is Alzheimer's disease. Okay. Now again, this is not available in clinical practice. Some of these things are not available in clinical practice. practice. If they are available, they would cost thousands of dollars. Because at this point, we haven't established it as a practice. And, you know, money's always short, so it's going to take a little time. Okay? The goal would be that if we could do something, a medication. Now, once we agree upon a diagnosis, we can work on the treatments. Because we can identify whether a particular treatment is helping or not if we first know exactly what we are looking for, what type of changes to expect. It is an important area because, like I told you, if 5.5 million Americans are affected by what we call dementia, there's probably several million who are in the wings, who are going in there. So it's a big unmet area that we could, if we could find some cure and help at that point. This is what happens to the brain. The brain shrinks. If you cut it, this is how it would look. The cells have shrunk and the sides these gaps become bigger. This is how we know that the cells are dying. I'm not going to this, these are some of the tests that I suggested. And let's move on to what else is happening here in Alzheimer's research. The plaques and tangles are the hallmarks of Alzheimer's disease. We don't know exactly how the plaques and tangles start to form in the brain, but we do know that they are formed and then they create other problems. They cause the destruction of cells, and we know how it progresses. We hope to know that what triggers formation of plaques and tangles at this point, but we are not at that point. So our strategy to treat Alzheimer's disease is directed, first of all, on diagnosis, and then figuring out how we can stop these plaques and tangles. Can we stop the plaques from forming, or can we remove them if they form? And same way with tangle. So different medications. So when you hear from a doctor about research, the doctor may say, okay, there is this one study, there is this study, there is that study. The problem is because they all directed towards different mechanisms. There is some overlap somewhere, but several are being tested with the hope that either we will need several of them, or we will need combinations, or one may be better than the other, or one may work and the other may not work. So therefore, there are several studies going on. Majority at this point are directed towards plaques. So anti-amyloid studies that are going on are directed towards either preventing the plaque from forming, or if the plaque is formed, to remove it. Somehow hasten its removal and clearance from the brain. This is what happens if you take the whole brain in a person with Alzheimer's disease, take it out in the advanced state. What you see here is the difference between this is normal brain and this is Alzheimer's disease brain. You see here the gaps between these? These are showing us that the cells have died and the brain has shrunk. On the MRI, you see some of it, but on the end, this is fairly advanced type of problem. So when you get an MRI in a very early stage, it's not going to look like this. There is some shrinkage that also happens as we age, but this is much more severe than just normal aging.
So, sir,
Yes.
are you saying that an MRI is not required to help diagnose a current patient?
MRI is not required to make a diagnosis of Alzheimer's disease. MRI helps, but it is not required. So if a doctor makes a diagnosis based upon their full assessment of examination and they don't see a need for MRI, then that's okay. Although we suggest that if somebody has had memory problems and they have never had an MRI or a CAT scan, just to have a baseline, it's a good idea to have it, but they are not required. It is not required for a diagnosis of